Hello, my name is Hamid Salah, and I'm presenting this case report on subclinical hyperthyroidism presenting as polyuria. So a little bit of background, there is a growing body of evidence to suggest hyperthyroidism is directly associated with increased urine production. Alterations in TSH have been shown to have an inverse relationship in renal blood flow and GFR. There's also a proposed mechanism by downregulation of aquaporin 1 and 2 in patients with hyperthyroidism. And then both overt and subclinical hyperthyroidism had a decrease in GFR after initiating therapy. And that change in GFR was actually comparable between the two groups. So Keith's presentation, we had an 82-year-old male who presented due to severe generalized weakness, low blood pressure readings at home, kind of a chronic cough, decreased appetite, intermittent diarrhea, and increased urinary frequency. He has a past medical history of pneumoconiosis secondary to silica exposure, multinodular, non-toxic thyroid goiter with tracheal deviation. He's had that for several years, and COPD, type 2 diabetes, hypertension, hyperlipidemia, TIA. He's also had recurrent hospitalizations within the past year for aspiration pneumonia. Upon further questioning, he does admit to having increased urinary frequency and urgency, but also excessive urine production, just passing excessive amounts of urine over the past month. The patient, he tried to stay hydrated well at home, drinking various electrolyte drinks, but he had a really hard time given that he had decreased appetite. He denies any burning with urination, fevers, chills, nausea, vomiting, chest pain, shortness of breath. He denies any new medications. He reports his cough is kind of chronic and unchanged. In terms of diagnostic workup, his vitals were stable, afebrile, non-tachycardic, saturations were appropriate on room air. His lungs clear to auscultation bilaterally without crackles. Exam was really non-contributory. On admission, he did have a leukocytosis of 14, and we'll go over his radiographic findings shortly, but really there was no acute findings there. He did have a small bump in his creatinine, orthostatic vitals were positive, and his urinalysis was negative. We did a barium swallow given that he's had this history of aspiration pneumonia. There was no signs of aspiration on that barium swallow. And this was the second one that was obtained within the past year, and both of them were normal. Later, we got a TSH given that he had increased urine production and that urinary frequency, diarrhea, and it did come back low. But T3 and T4 didn't result until after discharge, but they were within the normal range, and reverse T3 was elevated at 34. So we have his chest radiographs. CT showed faint heterogeneous opacities of the right lung, which is favored as chronic. And then here you can see the thyroid mass here on the right with tracheal deviation. You can also see that kind of tracheal deviation here in the chest X-ray. So we managed him with IV fluids, and that really helped resolve his generalized weakness. His AKI improved, his orthostatics resolved. As we only had the TSH prior to discharge, we started him on propranolol for what we thought was hyperthyroidism, and then we recommend that he follow up with endocrinology. Unfortunately, the patient was lost to follow-up, and it's unclear if the propranolol actually resolved his symptoms or provided long-term resolution. We suspect that this patient experienced increased urinary frequency, polyuria, and intermittent diarrhea because of his subclinical hyperthyroid state. With the increased urine production and inadequate hydration at home, the patient likely became hypovolemic and exhibited orthostatic hypotension, generalized weakness, and AKI. With the IV fluid hydration, his volume status normalized and his generalized weakness resolved. It's possible that the prior admissions that he's had in the past year were for suspected aspiration pneumonia were actually because of his subclinical hyperthyroid state. Several prior admissions had radiographic barium swallow study and physical exam findings that really weren't congruent with aspiration pneumonia. However, the thyroid mass with tracheal deviation, that's kind of an infrequent comorbidity and probably led to anchoring bias and bag wagon effect. So each time he was readmitted for aspiration pneumonia, it encouraged the assumption that the next admission would be for the same reason. With each admission, he probably received IV antibiotics and fluids, which resulted in clinical improvement of his symptoms. So in conclusion, we report in this case report that he had an atypical presentation of subclinical hyperthyroidism presenting as urinary frequency and polyuria. The diagnosis is easily missed, especially in patients with complex medical histories. And we aim to emphasize the importance of keeping hyperthyroidism on the differential, especially in the setting of urinary frequency without other clear etiologies. And then here are my references. And thank you for your time. I appreciate it.